All right, we'll go ahead and call the meeting to order. We have quite a bit on the agenda today. So at this time, if you would, please silence your cell phones as we get started. And at this time, I'll ask the Secretary to please call the roll.
Senator Rocky Adams, Senator Funky Fromeyer, Senator Harper Angel, Senator Mays Bledsoe, Representative Heverin, Representative Mosier, Representative Neighbors,
Here.
Representative Stalker,
Present.
Co-Chair Meredith, Co-Chair Meade.
Here. We do have a quorum and we are constituted to do business. First item on the agenda is approval of minutes. I'll take a motion for that. If anyone would like to make that. Motion and a second. All those in favor, please signify by saying aye. Motion carries and the minutes are approved. We'll move right on into the presentations this time. The first one is an update on child welfare in Kentucky. So Commissioner Dennis, if you would come to the testimony table along with any guests that you may have, please introduce yourselves and you may proceed anytime you'd like.
I'm Rachel Bingham with the courts. Do you want me now to start, or would you prefer that I come up after their presentation? How would you like?
However you all prefer to do is fine with me.
Okay, on the agenda, I'm first, so
We actually we moved the agenda around a little bit, and you may not have that updated agenda. We do have you on down just a little bit there, Rachel.
okay.
So
Do you want to just call me up when you're ready?
that'll be fine.
Thank you, sir.
Yep, thank you.
There's a whole crew of us up here. I'm Eric Friedland. I'm Secretary of the Cabinet for Health and Family Services, and if it's all right, we'll go around and introduce everybody. Perfect.
Good afternoon. Lisa Dennis, Commissioner for the Department for Community-Based Services.
Hi, I'm Melanie Taylor, Director in the Division of Protection and Permanency in DCBS.
Hello, I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services.
Hello, I'm Mary Carpenter. I'm an executive advisor in the Commissioner's Office with DCBS.
And behind me, come on up and
I'm Alan Brenzel. I'm the Medical Director for the State Department of Behavioral Health, Developmental, and Intellectual Disabilities.
Katie Marks, Commissioner for the Department for Behavioral Health, Developmental, and Intellectual Disabilities.
Hi, I'm Wesley Duke, General Counsel for the Cabinet, and my title's not as long as theirs.
Good afternoon, Kelly Poland. I'm the Executive Director for the SKY program at Aetna Better Health Kentucky.
Hello, I'm David Lord, Medical Director for DCBS.
So we'd like to begin. Understand that there are really questions from the committee, and we'd be happy to take those questions. Certainly there have been reports in the media about challenges that we face within our child welfare system. I believe many of us have testified about this previously in other committee meetings, and happy to talk about what we've attempted to do to address the issues, as well as what we hope to do and continue to learn as we move forward. I have just a little bit with me. We pulled.
Secretary, if you don't care, why don't you just give us a brief rundown on the situation as far as the media portrayed it, and and from your standpoint, what's exactly happening?
Sure. So I'll do that. We have many different states, and I think we've said this, that are in very similar situations. I'll be happy to send over to the committee the American Enterprise Institute, which listed about 11 states, actually not including Kentucky, that are having very similar issues in terms of what has been in the media around children in our offices. This started saw a little bit of it, probably starting about 6 to 8 months ago, maybe longer.
We first began in 2022 seeing the occasional youth that may need to spend a night in one of our DCBS offices because we were not able to find the appropriate placement. Beginning in July, we've seen that trend increasing in 2022. So beginning in July of 2022, we began actively tracking the occurrences when we had youth in what we call in non-traditional placements. So when a youth had to be boarded in a DCBS office, a hospital, a hotel, or other type setting. So we've been tracking since July 2022.
So that's been something that has been on the rise. There is no question about that. It is something that we wish never happened. It is a terrible outcome, not only for the child, but for the social worker and and it is one that we attempt in all sorts of ways to avoid. This group that I have here, so I just want to give you really a really solid example. This group comes together to discuss each child around placement needs, around placement possibilities. I think I've testified before again that Aetna has been a great partner with us to try to help us find spots. And those of you who've heard me testify before know that I don't often compliment our MCOs, but I do here. They have helped us with getting new providers in Kentucky, have helped us with wraparound services for kids in therapeutic foster care. So we've had, the number is about 100 and...
We've had since the beginning of this year, we've had 87 youth in non-traditional placements. So
since the beginning of the year, those 87 youth, about little more than half have ended up in what's called therapeutic foster care. So that would be a specialized foster home with services provided to assist that child in the home and to assist the foster care parent in dealing with what could be those behaviors. We've had about 30 kids who've ended up out of state, which is again not what we want, but we have had real struggles with finding placement in Kentucky. We've been working hard on that. We've worked with Medicaid to work on what's called a single case rate, where we try to tailor a payment rate and a service package to the individual child. I was very hopeful that would have a much greater impact than it has had. What we've heard from our provider community is that it's hard to build a business model on a one-by-one rate. We've got to look and do something else. We've contacted other states and requested what they are doing, and we haven't found the answer yet. We continue to look. This has been a real challenge for us, and frankly, a challenge for social workers who have to stay in offices, who get really. I talk about social workers as everyday heroes. This is another example of that, and that they will stay with these kids. Oftentimes it's short term, usually a day, maybe two. We occasionally have a kid who is longer because we can't find a placement. We currently have one child who has been with us a while, and we can't find in-state placement, out-of-state placement, or therapeutic foster placement. So we work on respite, and we work on finding a placement for this child, but this has been several weeks now.
He was with us, and we found a placement, and it disrupted, and he was back with us. I think maybe in a respite placement now, but this young man, yes, has been with us for a number of weeks on and off while we try to locate treatment and placement for him.
Here's the thread that runs through all these kids, pretty much. Obviously, tremendous abuse and neglect in the home, oftentimes sexual abuse, oftentimes physical abuse, which leads to behavioral health issues, PTSD issues, and when a child in any facility, hits or attacks a staff person, that becomes a very difficult child to place. And that is something when we met and talked about individual children, that was one of the threads that ran through most of the children that we're seeing. There are disruptive placements. There are times when that happens, but this is a challenge for Kentucky. No question about that. It is a national issue that we will continue to work on. I think out of the juvenile justice recommendations was a recommendation for state-run hospital. I get nervous about that. That's going to take too long. That will take years. We've got to find something more quick. And like I say, I was hoping the single case rate would work. I think we're going to have to look at seeing if there are ways that we can work with our provider community. We've met with the Hospital Association numerous times. We've met with the University of Louisville. We've met with Peace. We've met with Norton's. We've met with UK. And we have yet to find a satisfactory solution. But it is something that we work on actively every day. This is the team here. This is the group that works on it. This is the group that this is an individual. Each child is different. I know we know every child is different, but in this case, the needs are significantly different. The actions are significantly different. This child that we're talking about does well in school, does well on 2-to-1, does not do well in a facility-style setting. And I don't know how to say this, has a horrible history, right? It's horrendous. We believe in kids, and we think and we hope we can support them to lead better lives. Anything else anyone else would like to add? Okay.
What solutions? What are some potential solutions that could be offered for this situation? And is there anything that we can do legislatively to help fix some of this?
I think there may be. What we found out in talking to Peace, and what we found out in talking to some of the children's psychiatric hospitals, they are having difficulty moving children, discharging children, and finding a safe place as well. So they end up being full, which is what part of the challenge is. We think we need to look at rates in our PRTF, psychiatric residential treatment facilities. We are currently looking at rates in our psychiatric residential treatment facilities. Some of our sister states, North Carolina? I think that's right. Georgia has increased those rates. I think we need to look at increasing those rates. We will come with something hopefully fairly quickly around that. But it's finding the right rate. It's finding how we're able to support our partners. And I also think it's about working with some providers around, we call it no eject, no reject. That's kind of a term that we talk about. But it is, how do we collaborate on admissions and discharge for some of these kids? We're working on something now to see if there's something we can do there. But I hope we're weeks away. But I don't know that. We will certainly share that as soon as we have it. But as I said, the pieces around single case rate, finding additional services to support therapeutic foster care, which is a majority of where we've been able to find support for these kids. That's the sort of thing that we can use the assistance with as we move forward, and we will let you know as we move forward.
So you said the average stay, if they're having to stay in the offices, is 1 to 2 days?
Most of our youth are staying short term in our offices for 1 to 2 days. We do have the occasional youth that will stay longer. Based on our data, the longest we've had a youth, the longest number of consecutive days we've had a youth in the office is 17 days. Now, they may have been a break with a respite for a few days, and then they returned. We had the one youth that has done that over the course of the last few weeks, but he is the most extreme case. And so usually, yes, it's very short term, but we have had the occasion for longer stays.
And then I've just got one more question for right now. What services are offered to these children when they're staying in the cabinets buildings?
Of course, we're meeting all their immediate needs and making sure that they are safe and again, meeting their immediate needs. But it's difficult to provide services, therapeutic and clinical services in an office or temporary setting. We're currently, having conversations now with providers about some opportunities for that. But again, it's very difficult for continuity of care and just assessments for those youth to receive any type of clinical and therapeutic services in that temporary setting.
The YMCA's have been a partner with
Yes.
us for bathing, showering. We've made an arrangement now with the YMCA's that kids in foster care basically will be members. We'll have membership to YMCA's so that we can use them. It is not optimal. It just isn't.
And also in our more rural counties, we have a great relationship with a lot of faith-based organizations too, who support the department again with those opportunities for showering and different things, activities, engagement. So we do have plans around each of these youth when they're in the office to keep them engaged in, some level of recreational activity and making sure their basic needs are met for. So that either through different partnerships throughout the state, we have that in place.
I said I was done with questions, but I've got a couple more now that I've been thinking about it. So on an average, how many kids will be there in an office at night?
It is usually, 1 or 2 across the state at any given time. Would you not say? So it just varies depending on what's happening. But usually, 2 or 3 at any given time.
This is one of those trends that started in our more rural offices
Yes.
and then really spread to our urban offices. We were seeing that in smaller offices across the state first, and then in the
Beginning of this year, we really began to see it in the more urban areas.
And of course, most of our DCBS offices are located close to a city or a town, or
Correct.
a lot of times in the urban areas. With that being that number of children, 1 or 2, 3 a night, why does the state not partner with, say, a hotel or something to put those kids up for a night?
We do. That's one of the options as well. But depending on, again, some of these areas are very rural. There's not always an opportunity for a hotel to be nearby. Transporting these youth with some of these higher needs and behavioral health issues can be a risk as well. And then staffing can become a issue as also when you're in a hotel setting, if staff have to travel long distance back and forth. And then there's safety concerns, and we need to be in a setting such as the office where we can have additional supports around that youth. So it's all of that is gone. All that goes into the decision, but we have used hotels,
but it's pretty limited.
state parks. Yeah.
State park. It is. That's the exception, not the rule. When
Correct.
you look at our non-traditional placements, that's the rarity, and it really is. It's a safety issue, right? Most of these kids have acted out in a way that have disrupted placements, possibly with fighting, and so to put that youth in a hotel might also then, again, caveat always, social workers as everyday heroes, but you then might also put the general public at risk. So that's why that safety is such a hard thing to balance.
So if we're concerned about safety, what's making it more safe at an office building? I mean, are we locking those kids in a room by
No.
themselves, or what's What
but-
makes it more safe?
No, but it's limited to our staff. One, there's the general public concern, like the secretary stated, and then we have more staff there in the office available to help in the event that there is an incident. So staffing is easier for us in the office.
Yeah, we don't practice seclusion.
No.
It is usually then a 2-to-1 or 2-person, 2 social workers,
Correct.
2-way child, I guess occasionally 3, and our social workers are trained in de-escalation, and so I don't like it. It's horrible.
Mm-hmm.
Again, let me just say that. Our social workers are at some risk, no question. And that's just true.
Before we continue, I'll preface everything with this. I have no doubt about your heart and where you all stand. I know how you feel about the children. I know what you're doing, you care about. You are doing it because it's a passion, and you want to take care of those that are most vulnerable. So I just want to say that before we continue. But at this time, I'll turn it over to Senator Rocky Adams.
Thanks, Mr. Chairman. I just have a couple of questions as well. Right off the bat, do you pay your social workers more when they have to stay overnight?
They get paid overtime, and then they also get paid a shift premium of an additional $5 an hour.
Okay. And you testified that this was an issue that came to light in July of 2022. So I guess this being really a year old, how many more PRTF2 beds have come online in the last year?
None.
Okay, so how many therapeutic foster care families have come online since last year?
I don't know the answer to that, but we
could get
can
that.
get that.
Is it, ballpark it for me, is it 1, is it 20?
So I don't know exactly how many more have come on board, but across the state, we have many licensed beds. So for therapeutic foster care, we're probably only about 50% filled. It's more of the acuity of the children's needs that foster homes and agencies feel like that they can't accept a placement.
So we're only at 50% capacity, and then we have kids that are in government buildings. So why is that?
Largely, it's due to the acuity of the needs. These children have very high needs, behavioral needs, and clinical needs, and a lot of the therapeutic agencies for both residential and foster care just feel like they cannot therapeutically meet their needs in a setting. Now, that number does not include PRTF beds or psychiatric hospital beds. That's just therapeutic foster care, private agency beds, and residential beds.
Okay,
The issue is, if I may,
Sure.
that we have probably made hundreds of attempted placements for tens of kids. I mean, it is that kind of ratio where we have asked different facilities whether they will admit, and they will not. And we've experienced that across the board.
Does the cabinet have the authority to increase the reimbursement rates for PRTF2 beds?
We believe so.
Have you increased that rate?
We have not.
Why?
As I testified earlier, we were hoping that the single case rate, which would be above any of those rates, would clear the field, and it has not. So now we have to look back and what else can we do?
Okay, so you can imagine my consternation right now that we have testimony that kids have been in hotels, kids have been in government office buildings. The current rate structure that you attempted to use was unsuccessful. We have capacity, and we have the ability to raise rates. So
We found that the rates,
you're not, I mean, with all intents and purposes, and I'm very frustrated here, and I know that you all are frustrated too, but these are all non-answers. These are non-actionable items that we're seeing here. And I'm the first one to say, if you need some additional funds, if you need some additional authority, what is it that you need so that we can help you do your job better?
We have offered rates well above what any other rate we could possibly offer, and we've still had people say no. We've placed every child but one.
Do we have anybody from out of state that has offered to come in and contract for these services?
We are currently We're currently working to bring a provider into the state that is experienced in providing intensive in-home therapeutic services. So that may not necessarily help with a child that may be too acute for an in-home setting, but they are certified in multiple evidence-based practices and come in and provide therapy, care management, including targeted case management, as well as psychiatric services, and they have a psychiatrist available 24/7. So full wrap. That provider is currently getting credentialed and going through their application process in Kentucky with Medicaid. We are hoping that they will be ready to start to serve some children early in the fall, pending those approvals and that credentialing process. This will be the first time in quite a while that we've had intensive in-home services. I think that will help. That certainly is one piece of the puzzle, right? This is a complex continuum of care, and we're seeing, right, we need to have services at multiple levels of that continuum, but we do hope that helps.
Thank you. And thank you, Mr. Chairman. And I will reiterate once again that please let us know what we can do, because we need to get out of this situation that we're currently in. It's not good for you all. It's not good for the child. It's not good for our social workers. And we need a paradigm shift here. So thank you.
Representative Heverin.
Thank you, Chair. I want to actually ask a question off Senator Julie Rocky Adams. You said that a organization told you no, they would not take the child. How can they say no to a child if they have a state contract? To me, it sounds like they don't need a state contract if they're going to pick winners and losers of children.
It's a good question, but they control their admissions. And that is, we make referrals. Is that the right word?
Yes.
Okay, thank you. We make referrals, and they can choose not to accept the referral. And it's not just one organization. It is, that's why I said earlier about no rejection. We need somebody that we can say that to, right? If you don't do it, we're going to pull your contract. That's why we need to come up with another group of folks that will be able to do that. Again, I thought the single case rate was going to do it, but it didn't. So we're going to need to go in another direction. And so it's not just one facility. Senator Adams, to your point, a lot of the PRTFs that we've asked, and we don't have enough PRTFs, period. You are correct in that. They haven't been taking these kids either.
Can I make a comment? Thank you. I would be very interested in talking to them because I think most of them come and ask for funding from the state. Here comes 2024, the budget year, and they're going to start asking for money. And I would like to have the conversation with them to see, they're in business to help children, but they pick and choose who they help. I don't think that's very thoughtful. But I have great concern about the process, and I'd like to learn more about the contract process as well. That's all for right now. Thank you.
Representative Stalker.
Thank you, Chair. Couple of questions and perhaps a comment as well. But my first question is there any sort of common thread or profile as to the individual, the youth that fits the profile of what we're talking about when we're, discussing children not being able to be placed, staying in offices, as far as their age, their race, their gender identity, the length of time they've been in foster care, or the length of time that maybe that home has had an open CPS case on them. I'm just curious if you all are looking at those to see.
So when we talk, so when we talk about high acuity youth within DCBS, these are youth that usually present with intensive both behavioral and mental health needs, complex issues, and they're likely to be adolescents. Their average age is 15. The majority of them, 52%, are male. They're likely committed to DCBS for dependency. They have DJJ prior involvement or current or prior involvement. We have seen a trend with adoption disruptions as well as medically complex youth. The youth are often have behaviors that they're aggressive to self, others, and property. They have co-occurring physical health issues as well, and problematic sexual behaviors are the common characteristics that we're seeing within that population.
Dr. Lord, Dr.
May have
Brenzel.
more to add.
Again, Alan Brenzel, Medical Director for Behavioral Health and Child and Adolescent Psychiatrist, Associate Professor of Psychiatry at UK. And as I've been helping solve this issue for some time in my current position for 13 years. And one of the things I just like to add is that the reason this is complicated to solve is there is not one profile of one child, because this is like many problems we face in human services. It's a complex problem and it's going to require a complex solution. So there's a subset of these children that have autism, that have intellectual disabilities. There's a subset of these children who have primarily aggressive physical acting out, where they are unfortunately assaulting staff. There's a subset of these individuals that are self-injurious, that might swallow objects, that might cut themselves. So there's really, they do tend to primarily be adolescents. They do, I think, the minority and black children are probably overrepresented. About 2/3 of these are white, about 1/3 are black. They do tend to be from across the state, from all regions. But one of the things we learn on this call that all of us are on every morning is every morning there's a different twist to the different child as to why they can't be placed. Many of them need hospital level care. I would say about 1/3 of them need a hospital level care, which is the highest level of care we have in our system, acute psychiatric. But all of the current acute psychiatrics are saying they are too acute for them, which is really a challenge for us as the referral agency when our provider network is saying they can't serve them. So that's clearly an area we're exploring. What would it take to serve a children at a level above acute, or is there a need for a level or a subspecialization with a certain provider that can manage? But that will only solve about 1/3 of this, in my opinion. We need more psychiatric hospitals that can serve children with autism or on the autism spectrum. That would solve another 10%, I think. But a substantial number of these would need residential or therapeutic foster care. And I think that's the issue that we have, is what would it take to support those providers so that they'd be more willing, as Representative Heveron said, to take the more difficult child. Most of the referrals come from those providers, so they're giving the state a 2-week notice to say, we can no longer serve them. That's what's in their current contract, is within 2 weeks, they can give notice, and then the state has to go pick them up. And then we often ask for more time. We try to put in creative resources. We put in outpatient supports. And the sustainability payments made to providers, I think, were intended to allow them to provide additional clinical resources within their own agencies. But obviously some of them are just coming out of the struggles of staffing and increased salaries for direct care staff. But it is not going to be one simple 16-bed this or 10-bed this, or it'll solve this. It's going to require us developing high acuity level care services for kids with intellectual and disabilities, autistic services, and then the other population is kids with sexual reactivity and sexual offenses. Because you can't mix all of these kids together either in one program. That would be a disaster, to build a 24-bed hallway and put all of these kids. That would not be therapeutic and not be good for anyone. And so we do need many separate kinds of solutions that we are working on simultaneously.
Thank you. My question was really for the benefit of this committee. I am a former foster parent with the state for 6.5 years. So the description you gave me was not a surprise to me. But but I think it's important that people understand that is kind of the general profile of who you are trying to fit, so that folks could put a picture in their head. And as somebody who has received several calls in the 6.5 years that I was with the state, I've probably heard of every scenario where kids have burned every bridge, right? So to Representative Herron's, question about how can a child be rejected? I had the same question, like, what do you mean no one will take this child? And while I think it merits a conversation, I think the flip side to that coin is that we need to consider that program may not want that individual back for a multitude of reasons, and that individual actually may not be interested in going back either. Talking to kids and listening to some places that were easier for them and they felt supported, in other areas that just were not a good fit for a potential multitude of reasons. I'm just curious about what you did bring some things to light that I think are important as far as kids with the intellectual disabilities, which I've had kids that fit all of these profiles that you speak of. But also you'd mentioned when I asked about the profile about these kids that are already committed to the state. So there has already been a TPR, a termination of parental rights. These kids are officially in state's care until they age out or until they were to get adopted. And I'm curious about the length of time that these kids have been in foster care and or an open case of CPS with that family, because I think it's very difficult for us not to talk about that when we are where we are today. And we have to think about, we know the longer that kids bounce around in care, it does a lot of damage to them. And the older you get, all of a sudden you're a 15-year-old male, a black male. And I can tell you, nobody's lined up around the corner to take kiddos that fit that demographic. Unfortunately, we got a lot of people out there that want babies, and that's great. We need people who want the babies, but we also need people who will take all our other kiddos and give them a loving place to land. So I'm just curious about any data that you all might have for that.
I mean, comment first, but my colleague in DCBS will know. But another characteristics is, as you've mentioned, many of these kids have over 20 previous placements, and so as you can imagine, they don't trust adults. They are not necessarily sure anyone wants them. That's the saddest part about these morning calls is these are kids who are saying nobody wants me. What is wrong with me? But they will test limits, and some of that is part of a system that has failed to serve them earlier. I don't think we should ever have this conversation without talking about prevention, early intervention, support. We as a system share a lot of responsibility for creating these kids who are now what we call high acuity. The best thing we can ever do is stop creating them and prevent them, and we have to do that simultaneously. But these kids are with us, as you've mentioned. They have had more than 20 placements very often. Many of them are adoption disruptions. That really struck me. They are kids who were adopted at once upon a time who reached adolescence, and because of the changes in their behavior, the changes in their size, those families are no longer able to care for them in the community. And they've had adoption subsidies, they've had adoption supports, but there are families who, due to safety, I mean, we can't fault them and say what's wrong with them, because often they have other kids, they have safety issues, they have their own health issues, but a certain subset of these. But any other characteristics you all might want to describe of that, of the previous placements?
I think Dr. Brenzel summed it up well, and we do not have that data with us today, but we can go back and pull that.
Thank you. Thank you, Chair.
How many foster homes do we have right now?
I don't know, but we can get that for you.
Okay. I'm just, because I've got the number for 2019, which was 5,455. Is it gone up or is it gone down? Do we know?
Ballpark it.
I honestly don't know.
That's
I would
okay.
be afraid to even ballpark, but we can certainly get that. I mean, we can get it in. We have DCBS licensed homes and then therapeutic licensed homes with private agencies, but we can certainly get that quickly.
Okay. I'm going to switch gears just a little bit while I've got you up there to ask you some questions. We've talked a lot about behavioral health and the need for more behavioral health programs and things like that. Has the cabinet cut reimbursement rates to behavioral health service organizations in the last little bit recently?
So our behavioral health fee schedule, we had 2 behavioral health fee schedules. One was an inpatient, one was an outpatient. We combined those fee schedules, and when we did, we chose the highest rate on each one for the services. However, our behavioral health fee schedule is tied to the Medicare fee schedule. We pay a percentage of the Kentucky-specific Medicare fee schedule. So when Medicare changes their rates, our rates automatically align with theirs. However, this past year when that happened, we went back in and reverted back to our 2022 fee schedule so that there was a short period of time where there was a small reduction in some rates, but we have since corrected that and increased those rates back to the rate that was the highest prior to Medicare changing their rates.
So there was a reduction when Medicare reduced, and we had talked about and had talked through that we weren't going to reduce any rates. And it took a conversation, actually, I'll say them with Home of the Innocents, showing me where that rate was. They gave us a bunch of rate cells, and they showed where a rate had declined, and we went back to Medicaid, and we fixed it. So there was a period of time when the rate had declined, and actually, I didn't know. And it wasn't until I heard from Home of the Innocents, and actually ARC, I think, that brought that to light, and appreciate them coming forward and letting us know that we had made a mistake and needed to fix it.
So are those organizations now receiving a higher rate than they were before the Medicaid cut?
No
Just
less.
the same.
No less.
Okay. I would just say that we've known this problem has been going on since July 2022. It's probably been going on a little bit longer than that from my understanding. And for us, we're not involved in it every single day, so it's just kind of coming to light for us. And if we're talking about needing to raise rates or we're needing to put more investment into some of these services, whatever it may be, both Senator Adams and I are on the budget committee in order to put some of these things in that budget. We didn't hear anything about it the last time we did a budget. We haven't heard anything about it up until now. And I just think that we need to do a little bit better, I think, in communication between all of us in order to benefit the children a little bit more of this state. And I think these are our children that are the most vulnerable of this state, and we have failed them in several ways. And I think we all just need to pull together and start working together. You all have been very good at working with us. I can tell you, Secretary Friedlander, Commissioner Dennis, you've done a great job with working with us. And but I will say that the governor himself and his administration has not, and we need to do better in the future. Senator Adams.
You know, it's been said, and I appreciate the chairman's remarks, it's been said that here a couple of times that these are the kids that no one wants. These are the kids that no one wants. So let's not be the state that doesn't want them either. Thank you, Mr. Chairman.
Are there any further questions, comments? If not, we can continue. I think you all are pretty much there the entire time, so whatever you got next to present will be.
Thank you for this hearing. You and Senator Adams are correct. This is a tragedy. It's a tragedy. And it is something that none of us want. And Senator Adams, again, you are correct. We can't be that state. These are kids. These are kids. we need to do better, right? And we need to do better. Thanks.
Representative Hayward.
Thank you, Chair. I think we've had 3 closing statements, maybe 4. That's the ones that like to talk. Thank you for your remarks. But I do want to say with that, you all are their front line, all these organizations, that they come to you to have conversations. And I really do expect you all to put heat on these people, because they are. It's not the parents that don't want them. These are Kentucky's children. They're our future, and we need to love on them. And they're not getting love where they're at. And so how do we love on them? And I really expect a lot from you all, too, of putting heat on them and having the conversations with us. I know that I have an open door policy. I have no doubt that Senator Adams and Chairman Meade do as well. And it really does need to be a part of all of us working together. But it starts with you all, too, of having the hard conversations with those organizations, because we need answers. And I made a note, they're asking for more money, but nothing's getting better. And so why would we pay people more if they're not even able to do the job that they can to help our kids and our future? So just some food for thought on that. Thank you all, especially Secretary Friedlander. Thank you for your partnership in this new chairman role of mine. But I echo what Chairman Meade said, is it's not your administration that's doing it's the cabinet that is the open door and having the conversations. It's nothing from the governor's office. Thank you.
And I apologize. My co-chair, Senator Meredith, came in late due to a committee that he was in, and I forgot to ask him if he might have any comments or questions.
Thank you, Mr. Chair. I know it's difficult. I do. I think one of the things that concerns me, and Senator Adams made reference to it, as we put this budget together this next biennial, I'm not sure we've identified the total needs of the Medicaid program. I've met with 2 different groups this morning who have complained about their rates and no increases for 20 years. That particularly myself and Senator Carroll have some real issues about the waiver programs and the number of people we have on the waiting list. And I'm not on appropriation revenue anymore, so it's a little bit bothersome to me that Senator Adams, I don't know how we're going to address this unless we do it piecemeal. And I think that's part of the problem, is you rob Peter to pay Paul. And I'm not sure that's the best approach either. And that's not you folks. It's gone on for years and years and years. And I think we need a very frank, candid assessment of where is our Medicaid program with respect to each of these services that we offer, and where are the holes? Where can we establish some priorities? I think that's what most of us are so vocal about the expansion of Medicaid benefits, is how can we do that when we have so many of these other needs that are out there? So I don't know how we develop a comprehensive policy to try to identify what those needs are and address those needs. And I think this is kind of symptomatic of it, is we know it's been there. We know it's an issue, but we just hope it doesn't come to light. And then when it does, we have to react. And we like to be more proactive, and I'm not sure how we do it. Even if we identify all the Medicaid needs, we know that we can't fund everything, but I think the legislature should have some input into that process. And as part of that input, we accept part of the responsibility. I don't have any problem with that. But we need to know, and I think we should have some latitude in determining what those priorities are. And maybe it's a 10-year plan. We knock off this one, this biennial, and then forward. But I think we really need to know how, I think this is an appropriate word, underfunded our Medicaid program is, and how can we address that. And you've heard me 1,000 times, Secretary Friedlander, about there's enough money there to take care of everyone if we spend it the right way. And I'm still not convinced we're spending it the right way, both from a bureaucracy standpoint, administrative cost standpoint, improving the health of our population. We've got to be more focused on this and developing more comprehensive strategies how we're going to address all these shortfalls. And again, Senator Adams will quote me, one of my favorite sayings is, we never measure the cost of doing nothing. And I think if we did, we'd find out that a lot of costs there that we think we're neglecting, but we're not. It's just showing up someplace else. And that's what we have to do, is more comprehensive approach to this than we've had in the past. But my apologies for being late, Mr. Chair, but I appreciate the opportunity. Thank you.
Thank you all very much. Appreciate it. And Commissioner Dennis, I want to say I'm glad that you're in your position. You've been there a long time, and we've worked together on several things, and you're always very professional and always up front, and I really appreciate the job that you do.
Thank you.
Let's go. Yeah. Next, I'm going to ask Andrea and Melinda if they'll come up to give a presentation on CASA. And if you would, as you come up, just introduce yourself into the microphone.
Thank you for having us. I'm Andrea Bruns. I'm the State Director of the KCN.
You may have to push that button there.
Is that better?
Yeah, there you go.
Thank you. Good afternoon. I'm Andrea Bruns. I'm the State Director of the Kentucky CASA Network. We are the court-appointed Special Advocate Association in Kentucky. And I'll let Melinda Jameson with Lexington introduce herself.
Melinda Jameson. I am the Executive Director of the local program CASA of Lexington, serving Fayette, Bourbon, Woodford, Scott, Jessamine, Garrett, and Lincoln counties.
So we have a set presentation for you. I'm going to go through some slides. Melinda's going to start talking about the role of CASA, and I'll talk a little bit about where we are statewide and how we work with DCBS and the court system.
So as Andrea said, CASA stands for Court-Appointed Special Advocates, but what exactly is that? That is a trained and supervised volunteer that comes from our community. By Kentucky statute, they need to be at least 21 years of age. They undergo various background checks that we do on them. They are screened, and then they go through a 30-hour training. Once they have completed that training, they're sworn in by a judge, and then they are appointed to a case, and they are court appointed. And they are required to have at least 12 continuing education hours each year. But so the objective of a CASA volunteer is best interest advocacy on behalf of the child or children they represent, and we are looking for safe and permanent homes, and they do provide a written report that goes to the judge and all parties on that case that is in the best interest of those children. And in that report, there are recommendations at the end. And those recommendations could be anything from looking at termination of parental rights to maybe biological mom is doing well and we're suggesting that they begin overnight visits, or it could be something that maybe seems insignificant, like eyeglasses. But we had a young lady that was looking at being removed from the classroom. The CASA volunteer recommended eyeglasses. The judge ordered it, and within 2 weeks, she was moved into the advanced reading group. Education can break her out of a cycle that she was born into, no fault of her own. The CASA volunteer is a consistent for these children. They are required to have monthly visits with the child, and this little infographic sort of shows the process, but ultimately a judge needs to appoint a volunteer. We can't become engaged with a child until the judge appoints a CASA volunteer to the case. Then within our local programs, we work to match a volunteer to that child. We love when we can match a volunteer that is of the same gender identity, speaks the same language, knows the culture of a child, but that volunteer is appointed to that child or sibling set. We keep siblings together unless a sibling has perpetrated on another sibling, and then they get separate CASA volunteers. Or right now we have an 11-sibling case. It requires 3 CASA volunteers because the children are spread all over the state. But this sort of shows the process, so that volunteer continues to meet with them at least monthly, and if they're moved placements, that volunteer goes with them. So although my program serves 7 counties, I think we had kids in 68 counties last year. So our volunteers are driving all over the state to see these children. And so essentially the CASA volunteer stays involved until the case closes, and that can happen several different ways. And one difference is if the case closes, whether it's adoption or return home, the CASA volunteer can request to stay on that case for 3 to 6 months after. So although the cabinet is finished at that point, the CASA volunteer can stay to ensure hopefully disruption does not occur. But as we know, that sometimes does happen. So at my program, CASA of Lexington, we do cover the 7 counties. We are a 501c3, and currently in this fiscal year, 16% of our budget comes from the state general fund, to let you know what that percentage looks like. In 2022, for the calendar year, we had 247 CASA volunteers that were actively matched on a case, and we served 671 children over our 7 counties. And in case you're unaware, CASA volunteers are involved with Foster Care Review Board. We are invited to family team meetings. We work with the multidisciplinary teams in our different areas of service with the CAC and are involved in all of that. So CASA works with many partners. We do receive a court order by the judge specific to that case. And the report that I mentioned does go to the social workers as well as the GALs and all of the parties in that case and becomes part of the court record. We do also, by statute, communicate the child's wishes through those reports and with the GAL. And so we're sharing information and really just another set of eyes on that case. And most of our CASA volunteers have one case, so they can spend a whole lot more time dedicated to that one case. And the power through that written report is in providing those recommendations, like I mentioned, whether that is eyeglasses for a child or looking at return home to the family, the home of origin. So some things that we've seen happening at our local program throughout the 7 counties we serve is, I think we all know that during COVID and post-COVID, we saw the number of petitions go down. And Families First, we've definitely seen that cases are staying open longer. So although we've been recruiting more CASA volunteers, we're unable to serve as many children to some degree because it's taking more volunteers to serve those children because the length of a case has stayed open longer, at least in our area on the cases that we're assigned. We also have seen lack of foster care and residential placements. I think we talked about that at length already. I know my local program was requested to provide snacks and wipes for children in the office where we serve so the children could use the wipes since there were no showers available. That is not something we've currently partnered with, but that definitely brought it to my attention that there was some concern. But bigger than that, I think one of the things that concerns me and that we've seen in our program is with the, I believe it's on here too, the case acceptance criteria and at fault no longer being grounds, that the number of children coming in has definitely decreased, so that's a positive thing. But we've been assigned cases recently where we see there have been multiple visits to the home, but a case had not been opened. And so an example, 2 siblings, one was sexually abused, but the one that was not sexually abused did not meet the criteria. And so that, from my local program, my staff, that's our largest concern right now, even though we agree that it's concerning that we don't have enough placements for the children. We have, I think, a positive. We've seen that social worker turnover is improving in our areas. I think that's a great thing because the more consistent we can be with the cases, I think is a positive for everyone. But we definitely did see how there was turnover over the years, but now we're on a trend of improvement there. And we've definitely been appointed to more cases that have, a previous word used, acuity issues, including substance abuse disorder, mental health diagnoses, as well as older youth that have different challenges. And in some cases have to consider, is that an ideal case for a CASA volunteer even. I know in one of our counties, we were asked to go into a home where it was educational neglect, so there wasn't cabinet services in there, and the sibling of the child we were being appointed had gun charges. And so factoring in, do we send a volunteer into that home? So those are some of the trends we have seen at our local program.
A little bit about the KCN. We are in 92 of our 120 counties. When we started this work without any funding by the legislature in 2016, we were only in 36. So we're really proud of the development of the CASA network in Kentucky. We are the contractor of the state general funds, so we administer those funds to CASA of Lexington and to all the local CASA programs in Kentucky. We are in statute, so we provide technical assistance, training, quality assurance. As Melinda mentioned, CASA volunteers have to go through a very arduous 30-hour of pre-service training, background check. So we, in the KRS, we monitor for compliance. And our big issue is, and our work is really centered around building out the CASA network. So I have a couple slides that I'm really proud to share with you today that really demonstrates the investment by this legislature to build out this network. Here we were in August of 2015. You'll see, I think it's like in the high 30s here by the counties that were covered. And then here we are in today, July of 2023. So this is our growth plan. You may ask the question, why are we not in some of the other counties? So the answer to that is we have to be invited in by the judge. So we are making progress so that we can cover Kentucky with CASA, so that, as we heard earlier, when children are placed in residential foster care, we also are about 50% of our cases are kids who are not in care. So we are about family reunification when it is safe to do so, and about 50% of our kids are not in foster care. They are relative placement or in the home. And as you know, a case can start out not being in care, but then a child would be moved to care. So it's a little bit about our growth. This is our statewide data, just so that you can see. This is also in our biennial report, the number of children served. Our active volunteer number hit a high of 1313 actually in 2019. COVID, we saw a slight decrease, similar to what we're seeing across the country, a little bit of decline in volunteerism. But with our growth, we've been able to net some of that and to remain pretty constant. One of the things I wanted to point out here, as Melinda noted, is the decline of AOC petitions filed. That is generally a good thing, that children are not before the court. It has had an impact on some services that are not happening to kids who may still need them because it's not court active. If you, just to compare these numbers, if you looked at 2015, 2016 numbers on those AOC petitions filed, you're looking at 24,000. So you can see the decline. So generally that's a positive, but we can look at these last 3 years and look at the impact that COVID's had and reporting. So in terms of recommendations for improving child welfare, there's two things I want to point out. One is about CASA and how we can do our job a little bit better. We are a collaborative partner with DCBS and are working with DCBS leadership on the barriers that are happening with their migration in data. So a CASA volunteer will go back into TWIST, we don't have access to TWIST, but we'll go back into a trailer on a petition to do some really deep research on a placement, maybe 10 years back. As DCBS migrates to electronic system, that's going to become a little bit more challenging. So we're working with DCBS leadership to mitigate any barrier to our volunteers. We also want to sort of brag about, I think we have someone from Hardin County here. It's just it's a very simple solution where the DCBS office in Hardin County is partnering with a CASA program, and they've identified one staff person who is the CASA liaison. It seems pretty simple, but it's working really well. So when a case is closed or a case is still on a wait list, the program gets a heads up as to what cases are a priority. So we think that's a good pilot. And this is a small one, but in statute, it lists CHF employees cannot be a CASA volunteer. There is an inherent conflict with a DCBS employee, but we believe that a CHFS employee would be a great CASA volunteer. So in the next session, we will like to have some language that strikes the word CHFS, but just uses the word DCBS, because there would be a conflict with DCBS, but not CHFS. And then in terms of recommendations for the broader improvements into child welfare, so we believe that there should be an increase in guardian ad litem fees for court-appointed counsel. They're not paid very much at all. It impacts the CASA's role. Sometimes the guardian ad litem does not visit the child on the case. They have multiple cases and essentially are doing this pro bono. So we can see a big benefit in increasing that amount. Melinda mentioned a little bit, we didn't go into too much detail about the new risk of harm and the structured decision-making model, just working with DCBS about that for some additional training so that we're not leaving siblings in the home, and that training is being rolled out in every region. Also, more resources and support for fictive and relative placements for removals that are not court active. CASA is only involved when it's court active, but there's a lot of resources that fictive kin and relative placements need that aren't getting because they're not court active. And then support for family recovery courts. I'm not an expert on family recovery courts, but there's some great work being done in about 6 or 7 counties now. I know that VOA is doing. It's sort of, I think it's very CASA-like, and what drug court was doing is sort of triaging those cases, and there's some really significant success I know happening. Judge Harris in Jackson County, Clay County. So we think additional support for family recovery courts should be something that should be on all of our radar. So a little summary of our budget, where we were. I mentioned we were not in the state budget until 2016. We were one of 8 states at that time that did not receive any state funding. I'm happy to report, I believe, recently, I think Pennsylvania was the last, and West Virginia, every state now funds their CASA program. So we're very thankful about that. And this is a history. We were at 1.5 each year, 3 million in the biennial, dipped a little bit, 1.42 in 19 and 20. During COVID, maintained at 1.5, and then an increase this past year at 3 million. In terms of looking forward ahead into 25 and 2026 and the fiscal year budget, just to kind of give you, Melinda talked about their 16% of their program. Across the board, CASA is about, the state funds about 36% of all of our operations. So this past year, 2022, CASA programs spent about $7 million in expenses. We're looking to have some increased funding in those 2 upcoming years for many reasons. One, to build out our network, but the other thing to note is that there's going to be a decline in federal VOCA funding that is administered by the Justice and Public Safety Cabinet, and we want to, in CASA, as many providers in this work are very reliant on those funds. CASA stems to get impacted by that, so we want to get ahead of that problem. So this details what that increase would be. We take our stewardship of these dollars very seriously, and we put them to good use to serve children and to recruit volunteers, and would only ask for funds that enable us to continue to do that great work and to build out our network. So our request here at the bottom is $3.74 million per FY for each fiscal year in the next 2 years. So with that, I'm happy to take questions, as well as Melinda.
First off, thank you all for what you do. I am a big fan of CASA and what the work that you all do. I think that we've seen that outcomes improve when a CASA worker is helping work with that child. I do have just a couple of questions. So if you're in an area, that caseworker or that social worker, do they have to use you, or can they choose not to?
If so, we're appointed by the judge when there's a petition. So once the judge makes the CASA appointment order, they have to work with CASA. Yes, okay. Yes.
Does a judge appoint you in every single case?
It depends on the county. Some judges want to appoint CASA. They know there's not enough volunteers, but they want to make a statement to say, I would like a CASA volunteer, and they do. Other programs use it more as a triage, and the judge will say, let me know when you have a volunteer, and I'll give you a case. So it runs the gamut.
The reason I ask that is I work with NCSL in their child welfare group, and I was speaking with a representative from Indiana a couple of weeks ago, and he mentioned that in their state that the judge is required to appoint a CASA volunteer if they are in the area, and then of course the cabinet has to use them if that's the case. So just that's the reason I ask, is because I thought that was something potentially good to do, is to require that you guys be used in those areas.
Well, you may know in Indiana, the programs are paid per CASA volunteer assigned to a case. That is not the case here in Kentucky.
Right.
Yeah, and Indiana doesn't have attorneys. They don't have attorney representation for children, so not every child in Indiana gets a guardian ad litem. Yeah, so it's a little bit of, I work pretty closely with our state director there, but they don't all, so the reliance on CASA is even more important.
So what's it cost to make sure all 120 counties are covered?
Covered or fully served?
What would you like to request, Melinda?
So my vision, and Judge Brislin in Fayette County, she often says her dream is no child abuse, right? No child neglect, no child dependency. But the second next best solution is a CASA volunteer for every child. But as Andrea has said before, unfortunately, even if the money truck pulled up today, that wouldn't mean we could serve every child because it's a chicken and an egg. You have to recruit volunteers nationwide. Volunteerism is at the lowest rate it's been in 10 years, but that won't stop us. We'll just work harder to get there. But so what we're seeing, it's taking a lot more staff time to bring those numbers in, to recruit the volunteers. And then, of course, you got to train them. You don't get through 30 hours of training where the majority of your volunteers work full time immediately. So there's a bit of a process there. But Andrea, maybe you have a better number of how we get to all 120 and work to get to a higher percentage of children served.
So when we made this budget request in this current budget year, I said, if we got an increase, our goal is this first growth plan is to be in 100 counties by next summer. We were at like 79 when I asked. We're at 92, so we're over halfway there and meeting our goal. We will be working on that growth plan to build out, 25, 26. We're asking for the 3.75 rounded this per year, so 7.5. Again, it's about the recruitment piece. I will note this, that we are going to be launching next year, 2024. It will be the 40th anniversary of CASA coming to Kentucky. So CASA started in Jefferson County and in Nelson County. So we're going to be doing a big campaign around that. So how can you become involved with CASA? You can be a donor. You can be a board member. You can be a judge who wants us. You can be a volunteer. So really, CASA is a great movement. It's the everyday Kentuckian who can make a difference to the problems we've heard about today. So we do, though, want our growth to be successful. And it takes a board and it takes some business acumen to create these programs. We are doing some regionalization to help with that expansion. So we're asking for 7.5 in the next 2 year. I think that we could be by 2030. I think we can be maybe 2028. We could be in every county, and would love your help to make that happen.
And I can tell you from a local standpoint, currently our budget is 1.3. You heard that 16% of that comes from state dollars, and we're serving just shy of 20% of the need, if that gives you an idea on a local level.
And I am glad that you mentioned that you've got to have the volunteers there before the money is there, because I remember just a couple of years ago in one of the budgets I actually called and said that we had discussed in the budget conference committee about increasing your funding drastically, and you had mentioned that it was going to be hard to get the volunteers in order to roll it out that quickly. So
we want to be good stewards and hope that you believe that, and also we want sustainable growth. So even if an injection of funds come, as you heard, with VOCA dollars decreasing, and that's been the trend, we have to look at sustainably where can we raise those dollars. And, that's a big part of my job, looking to bring in individual dollars. But I think that makes a great model because it's a blend between government dollars and private dollars.
Are there any further questions or comments? Senator Bledsoe.
Thank you, Co-Chair. Thank you so much to both of you. I've worked with Melinda for a long time. I think you do phenomenal work in Lexington and the Central Kentucky area, no question. 20% of the need scares me to death, as we've talked about. Trying to find enough volunteers that can come and step in is critical, and you want to make sure that the right advocates that have the time and the effort to walk some really difficult cases. And so it is a sustainable growth challenge, and it's a funding challenge. I'm glad Chairman Meade asked the question about how much money it will take to get there and build up over time. So I think we want to make sure we're building it the right way, and we're bringing on the right tools for match money or other opportunities to help you privately fundraise. Because I think it's all of those pieces together. The more private money you have, the more investment you have from the community, the more likely you're going to have volunteers step up. So I just appreciate what you do, and I think we want to be good partners for that long term.
Well, thank you. And in 10 years, we've come from 1% to 20%. So we're destined for 100.
Representative Stalker.
Thank you both for being here today. I'm a huge fan of CASA. I had a kiddo who was fortunate enough to be assigned a CASA volunteer, and it was one of the probably the most important relationships that this individual who was in my home had, and it continued well after she left my care, and is now aged out. So I just cannot express how important I think some of these relationships that develop are. My question for you all is I felt like I heard you mention something about the model in Indiana. They do not have GALs, so guardian ad litems, which are basically like lawyers for kids while they're going through court. Did you say that they are not on a complete volunteer basis? Is there a pay structure in place for those individuals?
So there are some staff, I think, that it's also based on, I mean, there's also a lawsuit against the model with CAPTA in Indiana right now, so I wouldn't recommend that we look at that. But there are some programs that do some paid advocacy around that. But the guardian ad litems, there is some fee. There are some opportunities for fees, but it's not across the board. So they don't offer... They pay their guardian ad litems, but they're not mandatory in every abuse and neglect and dependency case. So some of the guardian ad litems are paid, but not across the board because they're not required. The way, I won't go into the details of CAPTA. States can interpret CAPTA in different ways, and there are a few, like Indiana, that have interpreted that to mean that there should not be agency representation for children. I don't agree with that. I think guardian ad litems are valuable and important, and that our model in Kentucky is great, and we should keep it that way. So they are compensated, but it's not across the board because they're not required in every state, in every petition.
Okay, so the compensation was really for the GALs, not the volunteers.
I think they may have some. They may have some that do a small paid advocacy model, but in Kentucky, I could argue against that for several reasons. One, it's unbiased. When you pay somebody to do something, it's a little bit of a different outcome. But I think in some cases, they do allow paid advocacy with some of their staff. We do say that a CASA staff person, when they become staff, they should take a case. So there are some paid advocacy in Kentucky. I don't want to mention that say that there's not. We actually have a standard that says it should be 10% of all your cases. So if a volunteer drops a case because they move out of state or they have a health issue, a staff person will pick up that case.
In some local programs, we have 0 paid staff at my program serving on a case.
I would be, just a quick comment, Chair. I would just be curious about us exploring what that looks like moving forward. It was just stated that volunteers are, declining at an all-time low. The same thing goes for philanthropy. So while I appreciate my backgrounds within the nonprofit sector, I always appreciate a good volunteer. It is not, unfortunately, a sustainable model, and particularly for these kiddos who need this care. And I would just encourage any sort of dialogue that we could have with you all or with other committee members about how we can fund you to the largest ability, because I do recognize we do have a chicken and an egg situation, and that's certainly not okay for the kids that are waiting who could really benefit from having a CASA advocate. So
yeah, and I would say the value with CASA, when a child knows that the person is there not because they're compensated, but because they generally care about them as an individual, as a person, as a child, it creates a relationship there that maybe the paid advocacy piece would put into question a little bit. But I understand what you're saying, and we're looking at, like I said, there's opportunities where sometimes that's needed, but our bread and butter really is around the advocacy model.
And I think there are ways to strengthen that. So one thing that we rolled out at our local program the year before last is a volunteer gas assistance fund. So as we look to remove barriers to make our volunteer corps representative of the children and families we serve, we're trying to reduce those barriers, right? And when we have volunteers that we're asking to commit 5 to 10 hours a month of your own time and drive 3.5 hours across the state each month, That's something we put in place. Do we have enough money to fund all of our volunteers? Absolutely not. That's privately raised dollars going and they have to request it. There's no assessment done. If they ask for it, they receive it. But I think there are measures that could be put in place that also don't lead to paying the volunteers to reduce some of those barriers with more funding.
Well, thank you all very much for being here this afternoon and giving us an update. Appreciate all that you do.
Great, thank you.
Rachel, you have sat patiently back there. Come on up and introduce yourself, and you can start anytime you'd like.
I just knew I was going to get, since you're down the road at the old Home Depot, just come on over another day. Thank you for having me, and to both the chairs, thank you for including the court system as well as to the task force. I would be remiss to not also introduce our new Administrative Office of the Courts, Director Katie Comstock, that is with us today, as well as our new Executive Officer for Family and Juvenile Services, Ashley Clark, that's going to assist by doing the slides.
Is that green light on?
Oh, I thought it was, but
there you go.
It was not.
Can you do that again?
I sure can. I can even sing it. No, I'm just kidding. Do you want me to say it again? Thanks to the chairs, as well as the task force, I'd like to introduce our new Administrative Office of the Courts Director, Katie Comstock, who is here with us today, as well as our new Executive Officer for Family and Juvenile Services, Ashley Clark, who's going to be kind enough to go through the slides for us. So we are here to just provide sort of an overview of the relationship that we have with the wonderful people that sit behind me. I said it's not like we're at a wedding. We're just one side of the family was on one side back there and the other side of the family was on the other. We work very closely with the cabinet as well as with CASA and our partners. So I think you all will get a really good feel of what that looks like, and to open up for any questions that you may have. So go ahead to the next slide. Just to start off, as many of you are familiar, the Administrative Office of the Courts does provide a rather complicated sometimes role within child welfare. We do support citizen foster care review boards. We have approximately 700 volunteers across the state, and those boards are able to review the cases of kids that are in out-of-home care due to abuse, neglect, and dependency, as well as those cases that specifically may be considered dependent that are also those status cases. So we definitely connected with the testimony from the cabinet in regards to the cases that they see on that high acuity and the complexity of those particular cases. We support the legal training around the dependency, neglect, and abuse cases, which are specific for those guardian ad litems. So the conversation that has happened around that particular group of that entity for the state has been very interesting. We have seen I've been here almost 27 years, and I have am yet to see pay equity for the guardian ad litems at the level that it should be for what they do to support and to assist and to really be there as an advocate for our kids. And we do a lot of work around those spaces with the court improvement program that for us in the court system comes through the Children's Bureau and really supports the dependency, neglect, and abuse populations that we serve. We have established most recently through the Commission on Mental Health a dependency, neglect, and abuse work group. They will actually, within weeks probably, I must say they are the fastest moving work group of the Commission, so we're very excited about that. We'll have recommendations to bring back to this particular group as well as others interested in the child welfare space for legislative recommendations. So we're excited about what they're going to bring. That entity is also involved with an initiative with the Department of Community-Based Services and stakeholders called Upstream, which hits on exactly the conversation about moving things back to prevention and the relevance on working in the space of prevention. How can we do what we call a sequential intercept mapping to be able to look at each contact point in the child welfare system and potentially come up with a different response, that it doesn't always require, obviously, as you know, removals and petitions and sometimes even detailed investigations. So those conversations have just begun and that mapping has just begun. And I would assume this group would probably be interested at some point in hearing how that work is going. And then we also are involved with our Title 4E, which is really, from the cabinet's lens, it's all of those individual children that are eligible to receive reimbursement if they are in out-of-home care with community-based services. For us, it is making sure that the forms are completed as they should, that eligibility is something that the court can verify and make sure that reasonable efforts has been made. And so we have a complicated relationship when you try to explain it, but it's pretty easy when we implement it, and that's that we're able to really provide a reimbursement opportunity for the court system on training and administrative supports to foster care review board as well as our judges and the court function. And so our role is, as you know, and I think that everyone is aware, that the Administrative Office of the Courts is a support arm. And so we provide that type of assistance to the judges across the state through Foster Care Review Board, through our stakeholders around practice and process. We do not dictate. We provide support. And we also do a lot of work with those entities around form development, around policy development. Many of you are familiar with our family court rules and really being able to do problem solving as issues or things occur locally that potentially we want to have, another layer of conversation about. Next slide. Specifically with community-based services, we do the Foster Care Review Board process. There is a statutory requirement to the community-based services to provide to our volunteers all the necessary documents for them to adequately be able to review our kids at a minimum of once every 6 months. The Child Welfare Oversight Council gave the opportunity for the CFCRBs to be able to do more work with not just only in the communities, but with community-based services around how we can get more resources and supports to our families and really get information from our communities. I want to give a shout out to community-based services. They've been present when we have our CFCRB regional forums. And one of the greatest things that they bring are actual answers to our community members, to our families, on how to access services and resources and supports. And so we don't just get the complaints at those particular forums, we actually get connections and we get partnerships with our families. And so we do a lot of work with community-based services in that space, as well as making sure that we're intentional on notices and information and case information. And that is an ongoing, never-ending cycle, as you would anticipate. Next slide, please. We also have external type activities. So not just the internal individual youth case, but we also have collaboratives that take a look at how we can communicate better as agencies, how we can support each other. We have connections with their iTwist application. We're able to utilize those resources. We're able to make sure that we have judicial participation at their review requirements and make sure that the Children's Bureau really hears from the court perspective and lens on the cases that they're reviewing, and that we have some real intentionality about that. And then I did mention also the Title 4E. There's a lot of collaborative education opportunities in that space. We also provide, it feels like we should have offices. Like, you guys sure you don't want to rent a space? And in the AOC, we spend so much time in being able to build our collaboratives. The family treatment courts that CASA mentioned is something that Volunteers of America has done a really wonderful job in being able to expand that program. They're moving into the chair's particular jurisdiction into Lincoln and Pulaski. They've also are looking to expand into a couple of more of our communities, and that growth into areas like Madison County, down to, I want to say, Hardin County, is really a great partnership for the local court and the Volunteers of America. And then they work directly with community-based services to provide that intense case management and treatment resources. And the courts have been very intentional, and community-based services has been a great partner in us all moving towards more of a recovery-oriented system of care. The concept of whatever door you come in, you're able to get the supports, resource access to hopefully make your contact with the system, which is never, we all know, is never great, at least potentially an opportunity to get to where you need to be. I did mention the Commission on Mental Health, and upstream, they are active participants in all of those groups, and cannot thank the Secretary for his commitment with the Commission. And for those of you that were able to attend our summit back in in May, we had over 1,000 attendees, and it was an amazing event, and we could not have done it without the cabinet's support and partnership and all of your participation. So we thank everyone for that. With CASA, we too have a great relationship, and was really thrilled to sit back and watch that presentation because when I came around, they were still scraping and trying to figure out how to even get them going and what could be done in the state, and it's really powerful. And I give a shout out to Andrea's leadership and the fact that she's been able to move the state as she has. We invite them to our CFCRB review meetings, and they are always there. The CASA volunteers are always present, always active, and are always sharing information that the volunteers are dependent upon. And they are also involved in our local community forums, again, as a resource for those community partners. And we are able to just connect people then instead of having to wait and figure out other ways. And then we share data, and constantly, as well as the opportunity for CASA to be able to get things like record checks done and things like that for their volunteers. And then we do a lot of training. That's one of the pieces that I think is unique that a lot of people don't know about the AOC is that we really try to have our stakeholders attend and participate and be involved in all of these opportunities. Next slide. So that's sort of us in a nutshell. I'm open up to any kind of questions or comments or anything that you may need from the courts outside of this presentation.
Well, thank you, Rachel, for being here today, and appreciate all that you do. You have been a terrific partner over the past several years as we've developed child welfare legislation, and you've been a key piece to that in getting us to where we needed to be with the court system. I will also say that I really, one of my focuses now is on prevention services, because I believe that the best way for us to help this state and to help families is to hold them together to begin with. And as we've heard that we're number one in abuse and neglect in the country, a large portion of that is due to neglect. And many of those families, it's not that they don't want to take care of their children, it's that they can't. They lack the resources in order to do it. And so I really appreciate you focusing on those prevention services to hold these families together. And I hope that we can have a greater discussion with us as a legislature, you as the courts, and the cabinet in order for us to all collaborate together in order to do that and roll out programs that really work.
Thank you. Yes, sir.
Do we have any questions or comments from the committee? If not, we made it easy on you.
Oh, wow. I hope the whole session goes like this, sir. Thank you all so much.
Thank you all. All right, we will move on into the implementation of House Joint Resolution 38. Mr. Sloan, if you could make your way to the testimony table with any guests that you may have, introduce yourself, and you may proceed.
Good afternoon, everyone. My name is John Holder, represent the Kentucky Board of EMS. I have with me Mr. Eddie Sloan, the Deputy Director for the board as well. We appreciate the opportunity to be here. Obviously, there are several challenges that face emergency medical services in the Commonwealth. Reimbursement would be toward the top of that list, and so we genuinely appreciate this task force and all the effort and time they're putting into exploring potential solutions to those challenges. This button. We're going to work this computer together. Back up just one. There we go. Good deal. We have a small presentation here that kind of may help make our point. Like I said, figure this out together. One of the issues that's being discussed is reimbursement for treatment in place via Medicaid. We'd like to present a little bit on what treatment in place looks like, what the perspective is from the EMS standpoint. And these are a few of the examples that we've pulled from our data. At the top there, you have treatment with refusal of transport. This is typically what people think of when they talk about treatment in place. This is when an ambulance crew will go to someone's residence or to a scene for an acute injury or illness, provide some form of treatment, and at the end of that treatment, the patient says, "I appreciate it very much," and then declines transport, which causes a problem for EMS reimbursement that we'll get to here in a little bit. Next, we have treatment without transport necessity. At some points, that's just not necessary to transport a patient to a facility, and so again, that causes a little bit of a problem we'll get to here in a little bit. Next, we have treatment with transport by personal vehicle. Again, a lot of times a patient, after receiving care, understands that a bill might follow an ambulance transport and declines and says, I'll just go ahead and take myself by car. We also have treatment by law enforcement. Occasionally, a patient will present some risk to a crew, and it becomes necessary for the law enforcement agency to transport that patient. Then we have evaluation with no treatment necessary. These are the best. These are when someone's not hurt or ill and there's nothing to treat, which is great for the patient. We appreciate that. Public assist, that's a big one as of late. We do a lot of lift assists, a lot of going to people's homes and assisting them with things where they're not necessarily injured. They just need a hand. And we love to do that kind of thing, but again, it doesn't end in a transport. And finally, we have patient deceased, and this is not as clear-cut as it may seem. If an EMS crew responds to a deceased patient and there's a potential to help that person, obviously they pull out all the stops. And they're using multiple medications, all of their skills, advanced airway treatment, things of that nature. And at the end of the encounter, unfortunately, sometimes those people cannot be revived. Again, no transport occurs. That's another treatment in place. So all that being said, what that basically boils down to is 15% of the time when an ambulance responds, we're not transporting. And that number has been pretty steady over the last several years. And the graph here just kind of breaks down that 15%. You'll see the big red portion there are our refusals. That's by far the biggest and creates a little bit of a problem. Now, in regard to Medicaid specifically, that 15% obviously is a very important number, but fewer of those will be Medicaid patients, and there's several reasons for that. Obviously, in different geographical regions of the state, there are different amounts of Medicaid patients, but also a lot of times if a patient refuses, it's because they're trying to not incur the ambulance transport bill. And sometimes with our Medicaid patients, it's not as big of a concern to them on the scene. And we've moved on here to the increasing incidence of treatment in place. And basically what we wanted to show everyone at the task force is that there's an increase in these type of incidents going on. We saw a pretty big bump in 2020 around the COVID time when patients really weren't wanting to be transported to the hospital. That continued on into 2021, and then we've seen a little bit of a decrease in 2022. This year, obviously, it remains to be seen what those numbers will look like, but annualizing the data up until this point, it looks like those numbers are going to be at least that much, if not more. Just to kind of share a little bit about what that costs to an EMS agency, we pulled the data on all the medications that were given on a treatment in place call in the last couple of years, and this is what we came up with, and we want to just kind of show what that is costing these agencies. The number you see at the bottom there is for the last couple of years. That's for supplies alone. That's for the medications and the supplies that were being used in these incidents. They don't. That number doesn't reflect paying personnel, maintenance costs to supplies, ambulances, diesel fuel, all that sort of thing. And it is a conservative number because we want to be careful with that. Go ahead to the next one if you don't mind. And again, so this leads us kind of to our issue a little bit when in regard specifically to Medicaid. As of right now, without transport, there's no reimbursement for those runs. And so these agencies are sending these crews out. They're providing this care. They're using these supplies, these skills, the training that they've gotten. And at the end of the day, there's no reimbursement for that, which causes a little bit of a concern. But this is my favorite slide of the deck here. This is the exciting part. So the good news is, however, it's our estimation that to allow reimbursement from Medicaid on these types of runs really is a win-win for everyone. And it may not seem like that when you talk about reimbursement, finding another avenue to pay someone to do something. However, we believe that if we can interject on these scenes and keep these patients, these low acuity patients, from being transported to the emergency department, it will actually be much more cost effective to do so. As it stands right now, if you think about the information we've just presented to you, EMS crews are incentivized to transport these patients, even the low acuity patients, because by the time you've gone out and you've done all these things, you've given this medicine, used up all these supplies, the only way your agency can get reimbursed by that is to transport. And sometimes that might not be necessary. And again, if there were a reimbursement option for these crews to not transport, the patient doesn't go to the emergency department, doesn't incur all those fees. And so hopefully there's an avenue here to be a little bit more effective with reimbursement. I think Senator Meredith was spot on when he said, discuss spending funds in the right way. If we can spend a smaller amount for an ambulance crew to handle these low acuity patients on scene without transporting to a facility, we can end up saving money in the long run. Some of the benefits here, I'm obviously not going to go over all of these. This is a lengthy slide. We want to be respectful of your time here, but it's a benefit for the patient, obviously, because there's a decreased healthcare cost if we don't transport. If we can handle a low acuity on scene and take care of the need, and they don't have to go to the emergency department, they don't get those bills, that helps them out in the long run in regard to cost. I want to jump down specifically to appropriate destinations for behavioral health emergencies. As many of you are aware, behavioral health is a big issue that we're looking into from the board standpoint right now, and trying to get those individuals to the most appropriate destinations. And again, going back to the transport rule in regard to reimbursement, our only ambulance agency's only option right now is to, if they want to be reimbursed, is to transport to an ED. And a lot of times that's not the best route. It's not the best route for the patient, and it's certainly not the best route sometimes for the emergency department staff as well. So if there were avenues to maybe treat in place and get those folks more appropriate care in a different way, I think that would absolutely be beneficial. Moving on to that center column there, facilities. Again, this one's fairly straightforward. If we can keep those low acuity patients out of our emergency departments who are having the same staffing issues as EMS services are having, that will take the burden off them as well, decrease crowding. I'd also like to mention that we can decrease ED wait times by doing that, by keeping that population out of the emergency departments. And we can also improve interfacility transfer times. I know that's been a topic of discussion as of late. And if we're keeping these low acuity patients out of the EDs, then one, they're not being overcrowded, and if the ambulance crews aren't spending time transporting patients that maybe didn't have to be transported, they're more available, which is fantastic for those facilities as well. And obviously this is good for EMS agencies. Again, we're incentivized to transport low acuity patients right now, but it would be better if we had other options. Go ahead to the next one if you don't mind. Looking forward a little bit, just a point we'd like to make from a board standpoint. Obviously, on the left there, we have a report from 1966, the Accidental Death and Disability Report, which was kind of the catalyst for modern EMS, and every good EMS personnel has probably heard of this report, or at least read it once or twice. And in that time, we're a fairly young profession if you think about it. In less than 60 years, we've gone from transporting patients from car accidents, putting them in vehicles just to move them from here to there, to some of the treatments that are being done in the field are pretty impressive in that time frame. But looking from there on, if you look at the right side of this slide, you'll see tiered response models where we're sending supervisors out in cars before the ambulance gets there, community paramedicine, crisis co-response services, emergency triage, treatment and transport, the ET3 model. All of these are treatment in place models. And we think this is a wonderful opportunity now in regard to Medicaid reimbursement for these. It's a wonderful opportunity to demonstrate a more efficient and cost-effective model to find folks healthcare options that are less costly and more appropriate. Go ahead to the next one. And so, anyway, that wraps up about treatment in place. We think there's some options there to spend funds more appropriately and keep the cost down in the long run. In regard to reimbursement as a whole, the last data we had, and admittedly it's a few years old, emergency transport across the Commonwealth, the cost of that ranged anywhere between $350 and $750. And again, that's not what's being charged, that's the cost. That's what's costing an ambulance crew to go on those specific runs. And as mentioned here, currently Medicaid reimburses approximately 10%. So for our EMS agencies, every time they turn a wheel on one of these specific runs with a patient who has Medicaid, they're losing roughly 90% of their cost. And that's significant, especially over the long term, and that's been going on for quite a while. If you'll see here, the reimbursement rates have been the same for the last 10 years. So it's a wonderful opportunity to go ahead and look at maybe changing some of that. I'd be remiss if I didn't bring up workforce shortages, and I know, again, I'm not going to belabor this point because I know it's been discussed in depth, but if you have low reimbursement, if you're losing money when you're providing a service, it's difficult to do much about things like wages and better equipment and things like that. This specific slide I thought was quite impactful, and I wanted to share it. If you'll notice that light blue column on the right-hand side, this is the number of certified EMS personnel that we have in Kentucky. Unfortunately, the dark blue column to the left, that's the number that are actually working. They're using their skills and training in the Commonwealth of Kentucky. Furthermore, we are losing more EMS personnel every year than we're training. We can't replace them as fast as we're losing them. There have been a bunch of surveys done to try to discern exactly what the cause is. Wages is at the top of that list. And again, it's difficult to increase your wages and improve wages if we don't have the reimbursement to make those funds available. So I thought that was interesting to pass along. So wrapping it up, basically, if reimbursement is unavailable for services whose demand is steadily increasing, the ability for ground ambulance agencies to continue providing those services at substantial risk. We want to go out and help these folks. We being EMS agencies want to go out and help. We mentioned lift assists earlier, but if we can't afford to keep those ambulance crews on the road, it's going to be difficult to go and do some of these things without some method of reimbursement. And again, if we can spend $80 on an ambulance run to keep a patient from going to the emergency department and incurring thousands of dollars worth of treatment, then that's a win for everyone. And with that, we'll take any questions.
I think we do have a couple questions from Representative Mosier.
Yes, ma'am.
Thank you, Mr. Chairman. Thank you for your presentation. You did a really good job of laying all this out.
Thank you.
I couldn't agree with you more that we would have huge benefits to the state and to addressing the high cost of health care if we looked at some programs like Treating in Place.
Yes,
I know all about the overutilization of the EDs and the high cost, and I mean it is a problem. So I know as a former flight nurse, there's a great deal of coordination with the hospital when you're out in the field. And do you feel pretty protected in making decisions about not to transport? And are there any liability concerns?
That's a great question. That's a fantastic question. There are some liability concerns. However, with any kind of treatment in place with most EMS agencies in the state, you do so under medical direction with a physician. Mm-hmm. And that's kind of how we envision this moving forward. When these decisions are being made, they're not being made in a vacuum, obviously. And so, yeah, there are some liability concerns, but at the end of the day, working with our physician partners, I think that it's still a safe route.
Okay. Yeah, I mean, that's really all. I think it's a great program. It makes a great deal of sense.
Yes, ma'am.
Yeah, I hope we can work something out. It's a good program. Thanks.
Yes, ma'am.
Senator Bledsoe.
Thank you, Mr. Chair, and thank you for your presentation. I'm very familiar with Lexington's paramedicine program. But I'm not familiar with the rest of the state. Are there other communities that have a paramedicine like Lexington's program?
Like a community paramedicine program?
Yes.
Yes, ma'am. I'm glad you bring that up. Community paramedicine is something that has been in a pilot for several years. The board is actively trying to bring that out of pilot program to make a steady certification. Community paramedicine has been very interesting in that the specific model is very diverse, and we're seeing that happen. How many community paramedicine programs do we have currently? Do you remember? 8 to 10. We'll go with 8 to 10. And each one's different, and they're filling the need of their individual communities. Mm-hmm. We have some that are looking to specifically keep hospital readmissions down, and they're being very successful at that. We have some that are essentially the ET3 model. They're going out and trying to discern if the patient actually needs an ambulance or not, because obviously of staffing concerns. So yeah, there are multiple places doing community paramedicine, and once we bring this out of pilot, we're really hoping that that takes off.
Okay, thank you.
Yes, ma'am.
Lexington, I was on Lexington Council for a long time, so we helped with the pilot, helped administer the pilot, put a lot of general fund dollars towards the program. And we have a social worker, a police detective, 2 paramedics and EMS in our program. And the goal was to reduce our high flight to just running people to and from the ambulances. I mean, that's the high cost on the taxpayer. Doesn't make a lot of sense. We diverted those funds to this program, and it does make it better. You're getting better care for the constituents, better return on investment for the taxpayer. It's interesting. You can't, you can take them to a hospital and get reimbursed, but not to a clinic or another third-party option. I think would be an important thing to do in that program. And the whole idea is to reduce costs, but also to provide better care.
Absolutely.
So I would be interested in seeing a better pilot me with that in mind, outside just Lexington, because I do think it's one of the best programs for that. And then 2, on this last workforce impact slide, is this only those that have that the Board of License that the Board of EMS does not license?
How do you mean?
So, for instance, the site clinics, industrial companies, or is this just the ambulance services that are in this?
This is total. Yes, ma'am.
It's total.
Yes, ma'am.
Okay, thank you. I'm interested, in this process, and I don't know if reimbursement Medicaid is the right way to take it, but I'm interested in finding a solution because I do think it works for Lexington really well. Thank you, Chair.
Thank you. Did you have something to add to that?
Well, thank you all for being here today. Really appreciate your presentation, and we look forward to working with you as we move forward.
Yes, sir. Thank you all for the time.
Commissioner Lee, if you want to make your way on up. I had offered for you to wait till the next one so we made sure you have enough time to present, and your response was, I can do this in 5 minutes. So,
I'm Lisa Lee. I'm the Commissioner for the Department for Medicaid Services. Pretty much done. What they said, pretty much done. So I can go ahead. I think I've got some really good information in this presentation. So I will go ahead and run through it really quick. So again, we all know what House Joint Resolution 38 stated. Treatment, triage, and transport. The Department for Medicaid Services has submitted a state plan amendment. It was submitted on July the 14th of 2023. We are proposing an effective date of January 1st of 2021 that will allow transportation to locations other than hospitals. Medical services have to be medically necessary, and regulation updates will be necessary. Alternate destinations, we are seeking approval to add alternate destinations, which include urgent treatment centers, medical clinics, behavioral health centers, physicians' offices, and again, limited to medical necessity for low acuity patients, and it will not be a substitute for non-emergency medical transportation, which is a program we already have in place for individuals to call and schedule transportation through a brokerage system. Treatment in place, no transport. Again, we submitted a state plan amendment on July the 14th of 2023 with an anticipated start date of January 1st, 2024. EMS providers may bill Medicaid for services rendered at the scene of an emergency call that does not result in patient transportation. Again, medical necessity. We have procedure codes. You can see that the reimbursement rate is going to be linked to the already existing rates for basic life support. They will not get mileage because there has been no transport, but they will receive services for rendering care. We expect our managed care organizations to follow suit with the fee-for-service program. Increase in ambulance reimbursement. We were asked to analyze this. We do have a directed payment approval with the Center for Medicare and Medicaid Services that allows ambulance providers to get increased reimbursements. They do pay the state match. It's about a 5.5% state match that those ambulance providers pay. There are 2 quality measures associated with that directed payment. And what a directed payment is a payment in which we, the Department for Medicaid Services, direct the managed care organizations to pay a certain percent to the providers. We do have 2 quality measures that's based on federal regulations. We have to promote access to high quality care by reducing ambulance response time and increase the number of certified EMS practitioners. So far, in 2021, ambulance providers, 172 ambulance providers across the state received $45.3 million in addition to their regularly scheduled submitted claims for reimbursement. In 2023, this year so far, they've received $28.4 million in addition. They do have supplemental payments are $358 for emergency transports and $101 for non-emergency transports. Last week, the Department for Medicaid Services received approval from CMS to implement mobile crisis intervention. As part of that, we do have a new definition with a two-person team that will include a behavioral health practitioner when emergency individuals go on site. The other thing that we will be doing as part of that is have a behavioral health crisis transport. You heard how behavioral health can be somewhat tricky, so we will have, this is intended to use between facilities. They will be able to transport to a 23-hour crisis observation, and they will be able to transport to inpatient psych hospitals. Provider eligibility requirements, they just have to meet the requirements established in the administrative regulations and meet all federal and state requirements. The vehicle will have to be staffed by two individuals, a driver and a support staff, and they will have to have availability every day, all day for the entire year, and they will have to go have annual staff training. And any questions on that? Done.
I'm an auctioneer. That's almost as good as me there. Do we have any questions for the commissioner? Well, you did a good job, and we appreciate you being here, appreciate what you do. You have a huge task in that department. That is a beast, and so appreciate the work you do over there as well. With that, our next meeting is August 22nd at 3 p.m. right here in this room. With that, I'll entertain a motion to adjourn.